Welcome to the Lean Blog Podcast. Visit our website at www.leanblog.org. Now, here's your host, Mark Graben.
Hi, this is Mark Graben. Welcome to episode 359 of the podcast. It is March 2nd, 2020, and joining me today from Switzerland is Professor Alfred to talk about lean healthcare. Now, I had a chance to meet up with Alfred. We visited a hospital together in Switzerland, north of Zurich, late last year. As we discussed, he actually had me as a guest on his healthcare podcast that we recorded together in his office. But this time, he joins me via the internet to be a guest here. We talk about his path into studying, teaching, and consulting on lean healthcare. We'll chat about what's different and what's similar in Swiss healthcare, and we'll touch on his books and his research articles and other publications in the conversation. So if you'd like to find the blog post for this episode with links to his webpage and his work, some of it's written in German, some of it is written in English, you can go to leanblog.org/359. Hi, Alfred. Thank you for joining us today on the podcast. How are you?
I'm great. Thanks for asking, Mark.
Yeah. So where are you joining us from?
I'm currently in Switzerland. To be more precise, I'm in a city called Winterthur that's around 15 minutes from Zurich, so in the north middle part of Switzerland.
Yeah, and I had a chance to come visit you, and I know it wasn't too far outside of Zurich by train, and we talked a lot. And you had me as a guest on your podcast, and I want to thank you for that. And if you can tell the listeners the exact name of your podcast and a little bit about your series.
Oh, that was a pleasure having you here in Switzerland and having you being a guest of my podcast. And now for everyone who's able to speak German, they will have it a little bit easier because you have to go to the webpage gesundheitswesen.org. And I think the best thing is to link in your podcast. Otherwise, it would be difficult to find it. But thanks again for being there, my guest.
Yeah, well, thank you for that. We did since I don't speak German, we did our episode in English, and I think if people search for your name in the podcast directories, I bet that will come up as well. So I'm going to turn the tables here, and we're going to talk more about your work and your books, and I want to hear about your experiences in Switzerland and beyond. Can maybe as far as introductions, can you talk a little bit about your role as a professor? What classes do you teach before we get into the research and writing that you do? What are you teaching?
Sure. I have three roles as a professor here in Switzerland, and the one is obviously teaching. So we have developed our own Master of Science program. And it's called healthcare management. So you can already think what this is about. How do we manage best our organizations? And big part of my teaching is also for healthcare professionals. I don't know how it is in the States, but if you become a nurse, if you become a physician, you tend not to hear a lot about managing business leadership during your studies. So people, as soon as they become leaders of their team, of the departments, they need some basic training in this. So they come to us to listen to, for example, how to implement lean. So that's the teaching part. But what is very important for us, if you want to teach good stories, you first need to experience them. It's not enough just to read them in the books. So what we do as well is consulting. So we go out there, talk to the organizations and try to help them to overcome their problems. And while doing so, we do our third job, that's research. So we try to, everything that we find out there, that we see out there, we try to combine that into theories and to publish it in different magazines, journals. And my personal research focus is obviously on lean management, especially on how this is changing the roles and the processes of the leaders in healthcare organizations. And the second part now becoming more and more important is everything about digital health. How is this transforming the way we lead and manage our organizations?
Yeah, so we'll have an opportunity to explore, not just lean, but we'll talk also about digital health. So I'm curious, how did you become interested in healthcare management, healthcare improvement? How did you become interested in that as a field and a discipline to study and teach?
It's a little bit a story similar to you, where, as the listeners have heard, I'm an industrial engineer from background and had business science and started working in different companies. And when I was all the knowledge I have about lean, I learned it as my time as a consultant for McKinsey, but that was just manufacturing related knowledge. So I didn't have anything to do with healthcare until 10 years ago. There was my boss coming into my room and saying, you know what, I have here usually taught a class on operations management to bachelors. And the last month I was invited to teach the same course to a class full of nurses and physicians. And you know what? They didn't like my course. But the thing is, well, surprisingly, the thing is, I don't have the power, energy to transform that course. But I have good news for you. I found a book here from a guy called Mark Rabin, and it says Lean Hospital. I have no idea if it's a good one or not, but take this book and redo the course. Yeah. And so basically, at the beginning, it was just an order, top down, like in a hierarchical situation. But I'm so happy that I started with that field, because I noticed very, very fast this is a fascinating field for many different reasons.
And I hope the book was at least okay.
I think the book was very, very inspiring. Yeah. And so, you know that, and I think you have heard it many times. It really helped me a lot, because this is exactly the kind of knowledge that we required at our university. It's not just some wild theories. If you are talking to a nurse or a physician, to anyone working in a hospital, they want to know real life experiences. They want to hear the stories, how to implement that. What's the purpose of all this? And so it's really, really helpful to say, some hospitals like this one described in the book has already implemented that, so it must work.
Yeah. And I apologize if it sounded like I was fishing for a compliment, but I do appreciate. I'm glad the book was useful, and so kind of stepping back a little bit to talking about educating physicians and nurses and other healthcare professionals. I think what I heard you saying was that they didn't like the course because the examples came from other industries.
Yes, and they didn't think this is relevant to them. If you were teaching them something about variation, about standardization, everything is fine if you're producing a car, if you're producing shoes. But if I'm here in a service sector and I'm dealing with persons, with feelings, why should I keep listening to you? So to make them clear that it's so relevant for your field as well, that's a challenge. And I think you had similar experiences in your life. Not everyone embraces the idea of, all right, let's talk about my processes and why I'm not working right at my hospital.
Yeah, and I think there are a lot of reasons for that. Like I think you said earlier, physicians and nurses and pharmacists and what have you generally don't receive management education during their professional training, right?
Indeed. And that's a shame. But we try to change that many times, that within our university, we are training nurses and other healthcare professionals. And they just canceled my course on business basics. So you see, it's still, at least in our country, still not really changing that situation.
I'm sorry to hear that, but thanks.
Yeah.
There's, there's so much opportunity, like you said, to help people view their work as a process, as a fundamental step to being able to talk about improving processes. And I think that's a challenge when people view their work as basically, my own individual effort, and everyone is trained to focus on their own individual excellence. That doesn't lead to a great system, right?
That's true. And what is for me fascinating, and 10 years ago, is when I first understood that, yes, the transfer of knowledge to the healthcare sector is very important for many reasons. First of all, we are talking about human lives. So why we should improve the processes should be pretty crystal clear for everyone. The second thing was about, healthcare in Switzerland is lagging maybe 15, 20 years other industrial sectors. So there's so much improvement potential. Yeah, and the third part of that was that there's a lot of money in the system, but also a lot of waste. So this combination of it's important, you're lagging behind, and you would have the resource to change something. So let's try to do it. That was my approach.
Yeah. So before we talk more about lean, I think it would be interesting to maybe set some context for the listeners about the Swiss healthcare system, because I think in the U.S., a lot of people generalize about the systems outside of America being all the same, and that's not the case. So for example, you have the British model where you have primarily government-owned hospitals, the government as a payer, doctors being employees of the NHS. Or then you have the Canadian model where it's definitely a single payer model, but primarily privately owned hospitals and clinics. Or you have the Dutch model, which has insurance companies involved. I mean, how would you characterize the Swiss system?
So it's neither of those systems. It's always a combination of many different ideas. But I think the easiest thing to describe is to think about it is a free market, but highly regulated, meaning that, for example, the insurance market. So basically, everyone is able to open their own insurance company, health insurance company. And you as a citizens, you can freely choose among them. You can change every year your insurance if you want, but, and that's the mandatory part, you must have one. There is not a single citizen here in this country without insurance coverage. So there is no situation where you can drop out of the system. And if you refuse to choose one for whatever reasons, then this government is going to force you into one. So that's something that's, first of all, most for Americans guests visiting us, one big difference, saying that there is not a single person in this country that's not insured. And also, well, you have to pay for it. There are some fees for that. If you cannot afford them, you're going to get subsidized. So it's really, there's no way that you can drop out of the system because you don't have enough money. And
I'm sorry, go ahead.
No, I was just going to say, but the thing is about choosing the different insurance companies is not that, how can I say, it's not that difficult, because basically they are all forced to offer you the same services. So there's all this insurance are offering you the same access to hospitals and the same treatments, and the only thing that changes is the price. So there's only a price competition, but not a content competition on that. And
you answered the question that I was about to ask there in terms of similar coverage. It's the same coverage. It's the
same coverage. So you don't have to think, oh, I have diabetes, maybe I should Google them, maybe I shouldn't tell them. Yeah, they don't care. And you pay the same amount regardless regardless of your income or your risk group. So the only thing is they're trying to compete on the administrative side, saying, well, we have the least administration costs, so we can offer you coverage for a lower amount. So on the one hand, free market. On the other hand, not that much, because as an insurance company, the product is forced to you and you're forced to take everyone. And so, yeah, a mixture of socialist system and free market.
Yeah. And so then the insurance companies are paying a mix of, are there some public hospitals and then there are university hospitals and other private hospitals?
Exactly. So there's a wide a combination of privately owned, public owned, and for-profit, non-for-profit hospitals. But as a rough estimation, so most hospitals are more or less not for profit. So the real private hospitals trying to maximize their income, they would be maybe 10% or 15% of the hospitals.
Mm-hmm. And then is the payment still primarily a fee-for-service model?
Yes. So that's one big issue, obviously, that there's a lot of money in the system, and luckily there is the states, because otherwise we would be the most expensive country on this planet. We are giving 12% of our GDP to healthcare. You are, I think it's around 17%. 18 by now.
Some estimate, yeah.
Okay. So, and yes, so fee for service is the typical situation. There's a lot of talk about changing this, but you know how hard this is to really implement any value-based healthcare system.
Yeah, that certainly is. That is a challenge. So it sounds like, for one, before we talk about hospitals and healthcare organizations, you talk about the insurance companies competing. If they have a more efficient administrative back end, they can then probably offer a lower price. Have you worked with insurance companies that maybe use lean in those administrative processes?
Yes, they didn't call it lean, but it would, the game, like sometimes you're not allowed to call it lean because some manager has heard that it's about getting rid of people. But yes, I was actually in a project involved where there was their interface between a hospital and insurance company. We had the chance to have a look into that. So basically the hospital makes some services, sends the bill to the insurance company, they have to pay it, and it's surprising how many hundreds of processes happen between a hospital and insurance company where as a patient you don't get anything, you don't know anything about what's happening there, but it's hundreds and hundreds and hundreds of people talking to each other. So just to make sure that the money flows between both organizations.
Yeah. So then when we talk about hospitals or other healthcare settings, what's their motivation in Switzerland for lean? You were talking earlier about learning how to teach healthcare professionals, how to help pique their interest. But whether we're talking about healthcare professionals or maybe the executives that run hospitals, what do you see as the primary motivations for lean?
Well, what everyone says is always about the patient, patient first. But that's not always the true reason to start a lean project, if I may be very honest here. Yeah? So indeed, I think we have to make a difference between the executives and the healthcare professionals. So in my experience, there's a lot of money in the system, but yet the pressure is increasing to get the cost down. So many executives think also about money. Even they're not for profit, they have to make sure that they earn enough to refinance themselves in the long run. So money will be always an issue. But in addition, what they have, the executives on their mind, is always about staff shortage. So we can only survive here in Switzerland because we are heavily importing physicians and nurses from the countries around us. Otherwise, we would completely have a shortage here. Just to give you a rough estimate, we are training maybe 1/3 of the doctors we need in this country. So 2/3 have to come from somewhere else, logically, if you don't want to have really shortages here. So it's about money, but it's also about treating your staff in the right way. And yes, obviously the patient should not suffer at any moment. If you think about the health professionals, Well, we had a study in one hospital here, in one university hospital, where we tried to assess and measure with Gemba walks how much time do they really spend in their main role, dealing with patients. And so the typical Swiss doctor that we observed was around 20% of their time really dealing with patients in a hospital setting. So 80% is other stuff. And this other stuff, some of that might be useful, like documenting the right things that you need for the therapy. But for example, 50% of their time they were sitting in meetings. And no one can tell me that you really need, or the best way to organize this hospital is having your physicians 50% of their time in meetings. So some of that time might be really valuable, but there must be so much waste in those meetings. And everyone who has been in meeting in an industrial setting or healthcare setting knows that not all the time or you are in a meeting is really value adding.
Yeah. Well, and then there's the time spent on the computer and the electronic health record systems, right?
Yes, that's maybe 1/3. Well, in our numbers, it was 1/3 of their time, something like that. They were doing recording things, writing things down, and that makes it very difficult for us if you do like the typical split and you want to find out how much waste is in the system, because you see people writing things down and it could be that they're exactly the information you need in the next step, or it could be that they're just very, very cautious because they know from the lawyers you have to write everything, little thing down, otherwise you will get trouble later on. Yeah. So it's
or to make sure you get paid by the insurance company.
Yes, well, that's obviously the most important thing. You should start writing, And so, a lot of waste hidden there, meaning that if I talk to healthcare professionals and if I promise them or I give them the vision, what about if you could, after 15 years of studying, spending more time on what you learned there, what your passion is? That's what's most interesting for healthcare professionals. How do I reduce the time, the administrative time with Lean?
Yeah, increasing time at the bedside. And then that leads to all sorts of other effects around reducing harm, other really important benefits. So I'm going to jump ahead a little bit. We'll come back to some of the other topics we'd plan to talk about with Lean, but when you talk about focusing on the patient and the needs of the patient, there's one article that you've published, and it's titled "A Case Study: More Patient Safety by Design: System-Based Approaches for Hospitals." So, before talking about that article a little bit, I'm curious, how well known are rates of medical error, harm, death due to medical error in Switzerland?
Well, that's the big issue here as well. I think we have a really good system. Everyone believes that, but we cannot really prove it. So we are very fragmented, meaning that we force our hospitals, for example, to have tons and tons and tons of quality data. That you can is then available if you know where to look. But the thing is, as soon as the patient leaves the hospital and goes to another provider, the track is completely lost. So we have just little snapshots of the quality in this 2-week hospital stage was good. But if this leads that to a patient that 2 years later has to ends his life in a rehab center, and because he got some issues, complication with what happened in the hospital, we cannot track that. So we are in a very strange situation. Every single provider forced to have good data, but we don't have transparency on the whole system.
So I imagine, are there attempts to estimate? Or have there been studies? In your article, you reference it's now 20 years old. The study from the United States, "To Err is Human," and
yes,
the different studies that have been done since that try to estimate levels of harm and death. It's based off of small samples and reviewing charts and trying to determine what was caused by error and what was preventable. Those estimates are very wide ranging.
Oh yeah.
Is there a similar attempt in Switzerland?
Yeah. One number that is very striking is that we have every year, Switzerland is a small country with 8 million, we have around 300 persons dying in the street because of traffic accidents. And the estimation is 5 to 10 times that number dies in hospitals because of errors. So you see there, you see the gap there that's still to be closed.
Yeah. And one thing I've seen when I've seen numbers, the per capita numbers, for example, the United States and Canada, with two very different structures of their health system, the per capita rates are almost exactly the same, which to me is not surprising because I've visited and worked with many hospitals in Canada, and the way the work is done is very similar. Some of the concerns about communication and teamwork and staffing levels, those are very much the same across countries. So to me, it's not surprising that per capita rates might be very close.
Yeah. On the other hand, I have to say, well, the life expectancy here in Switzerland is 83 years. And so that overall, it's still very good. It's not like people are dying like flies in hospitals. I don't want to give that impression. But every death obviously is death too much. And every harm is not always about death.
Yeah. So can you talk a little bit more about your article when you talk about working environments and system design? What were some of the key findings from that article about improving patient safety?
Sure. The thing is, that's not a new research field. So as you mentioned before, looking at why we do errors and try to prevent them, that has been being focused on the last decades. But the funny thing is that many times, many articles focus a lot on the process and the human behavior. And there's one famous statement that says that we cannot change the human condition, but we can change the conditions under which humans work. So sometimes, as you know, it's much easier to change the system around persons and not the person itself. So well, as a friend of Deming and Lean, most of the errors belong to the system. And so what we are trying in that article, in that research effort, was more not to invent new systematic prevention of issues or of a risk, but just to collect them and think about how can we make sure that people know that this risk can be mitigated by having the right systematic approach to that. So that was the main purpose of that.
Yeah, because I'm curious how much you hear discussion around, I hear hospital leaders or even medical professionals, they'll talk about errors and they'll say, well, some of this comes down to human error and, humans are imperfect and it's human nature and humans are fallible. So, when it's human error, what can you do about that? Well, you can, I think like what you're saying, we can't expect people to be perfect, but we can improve the system. That's what you're saying.
Exactly. And it's much easier, if you don't give the people the opportunity to make an error, Bukayoke and co. It's so much easier than teach them and give them courses and explain them why it's important. Just don't let the error happen. Yeah. And so, but whenever you start building a new hospital, I think this is very, very, the last page maybe on your concept about safety and safety issues. You think a lot the architects think a lot about how to make this beautiful, how to win the competition. And not so much how can we make in a safe environment so that people can conduct their processes in a safe way.
Yeah. So kind of stepping back and, looking at lean within Swiss healthcare, I'm going to ask you, and it's a difficult question, and I forget if you asked me or people ask me, it's this version of a question of, how many hospitals in the United States are implementing lean or whatever verb seems appropriate. And it's hard to know, but if I were to ask you the question of, how widespread is lean in Swiss healthcare? Is it possible to generalize, or what's your impression?
Mm-hmm. Yeah, that's a question that we get all the time. And I guess my answer will be a wild guess, as I don't think that any country can really answer that question. But I would say it like we have around 280 hospitals here in Switzerland. And I once tried to collect every single lean optimization I found out there. And I had soon to give up because this is so much data and so fast outdated. And people sometimes implement lean, but they don't talk about it because they're ashamed or because it didn't or didn't go well. But to answer your question, I would widely guess between 20 and 30% of Swiss hospitals have made at least a lean pilot in some part of their organization.
Yeah. And boy, the challenge of trying to go and track all that down. In the United States, I think there are about 6,000 hospitals. And like you said, there's no public reporting, and it might be fair to say not all lean efforts are created equally. So if somebody has done 5S in a couple of departments, does that count the same as an organization that's really trying to change their culture and their management system?
Yes, it's really hard to count. And the good thing is, I would say, is I don't think that there would be a hospital who not at least a couple of people have heard about lean. And if you would ask in a survey, what is your preferred way of improving processes, I'm for sure that lean would be number one. So it's starting to become like the standard procedure if you really want to improve your processes. So I wouldn't think any other improving philosophy is as close to be number one as lean.
Yeah. So can you share an example or some examples of, a hospital or a clinic that you've seen or worked with that has had made good progress with lean? I'm not going to ask you the question I get sometimes is like, well, who's the best? And who knows? I don't like to say that. So I'm not asking you who's best, but can you share at least an example, whether you can name names of the organization or not? What are some examples of good progress there?
Sure. Yeah, who's the best? Depends who has the best marketing department, I would guess. Well, what we observe here is that indeed hospitals started first. So from all healthcare providers, it were the hospitals who started with lean and have taken the leading role since then. And what we have seen there is like a division between the big university hospitals and some small, more independent hospitals. And so I think one of the first hospitals for sure were the big university hospitals in Bern or in Basel. And what they did at the beginning is very typical is to get some external help. So some big consulting company to getting things started. And then once the pilot project was done, they tried to implement that into the organization. So this hospitals, and when I say big, I'm talking about 800, 900 beds. And that's for us, it's a big hospital. They have by now like a central department, central organization helping anyone in the hospital implementing lean. So this is already a big step forward for us to say, okay, I'm in a ward and I would like to improve my processes. I can call those persons in the central staff organization that will help me with my processes. So that's one approach, one more institutionalized approach. And the other examples are more like single independent middle managers who decide, I want to have that in my department. And so not from the top, not from the bottom, but somewhere in between, they decide, I want to change my eye clinic and become better. So those are the two sort of good examples I see here. But if you ask me, is there a lean hospital out there? Well, you could argue there's no one in the planet because it's a process, not a status you reach. But even being, is there a hospital where you would say everyone has had a training in lean and has implemented that? No, that does not yet exist here in Switzerland.
Yeah. So it's not yes, no, lean or not lean. I kind of, try to think of it and categorize it as, if you were have two categories, we're still working at it and figuring it out, or we've given up, or maybe there's some who haven't started, but so I've seen a lot of cases where somebody who runs a department is inspired to start practicing lean, and they can make a big difference within their department or maybe their value stream, even if it's not fully endorsed for the organization by the chief executive, right?
Indeed. Funny enough, it started here in certain departments. So it was the typical hospital wards and in the emergency room. Those were the two parts of a hospital who were making, the first ones with like clinical approach or clinical processes. Before that, even that the very first lean case I heard in a Swiss hospital was about logistics. So there was in the eastern part of this country in St. Gallen, the logistics manager there, he came from IKEA. And so he decided, well, what's happening in this hospital? I know it's completely different from my previous experience. And he started that time changing the processes and introducing Kanban and looking at inventory. So that's a typical approach here. Logistics, then maybe the emergency department, and then maybe the most hard part is to go to the operating room.
Yeah, so maybe let's talk about that, because I know you've done some research, in particular with lean and operating rooms. Can you tell us more about maybe what some of the challenges have been, or how people have addressed those challenges?
Yes, for sure. So if I talk about the research on that, because when we decided maybe it would be interesting to have a look at lean in operating rooms. So the first thing as an academician, what you do is you do a literature review. If you don't know what to do, just complete or try to collect everything that you can find about the knowledge out there. So what we did there was a team of about 7 persons, and we went to the databases and started looking for keywords like surgical unit, optimization, improvement, and so forth and so on. And then we got like 700 documents. You scan them and notice that in our case, 115 were like really studies and solid research, not only marketing from some consulting companies. And then you go in deep dive there to try to find out what do we really know about how to improve an operating room in that case. Yeah. And yes, what you find out there is you will always find the same hurdles and the same challenges that we have anywhere else, and we can deep dive that a little bit later. But especially for an operating room, what we notice is that if you think about methods and about tools, how to implement lean in an operating room, there were basically non-existing tools that are specific for the operating room. So most of the papers we analyzed, there were just some scheduling, mathematical formulas, very complicated. I don't think they had anything to do with real life, with practical life. So the first lesson there was there is no specific way to introduce lean to an operating room. What second finding of that project was that are only like 12% of the papers out there dealt with the soft sides of lean introduction. So I'm not telling you anything new when you say it's all about people and you have to convince the people, and it's a lot about emotions when you're trying to implement lean. But all this operating room process improvement papers, or not all, but 90% were about the hard facts. And so anything about how to introduce change, how to make your team work better, almost nothing on that part. So we notice very fast, this is a real big knowledge gap. And maybe the third insight from that study was that there was not a single paper telling you how to do it. How should I really transform? So the cooking recipe, how do I start as a manager if I decide I want in the next years to have a real smooth running, lean operating room? No one is telling you that in academian world.
Mm. And so when you talk about the soft side, so as industrial engineers, we can probably quickly imagine all of the possible mathematical optimization, linear programming, simulation, topics that we could delve into. But then, as engineers, or let's say somebody determines, the best or the correct model, that doesn't mean that model is going to be accepted, which now comes back to that soft side. And maybe, we can transition and talk about some other research that you've done about change acceptance, or, can be framed as resistance to change. Can you talk more about that?
Sure. So I think this is a maturity problem, because as an engineer, the easiest thing is to take a computer, make a simulation, and it's fine. And that's, I'm not saying this is not important. This is very important. But this can be only the first step. Then you have to go with your computer, your results, and stand in front of people and create some motivation, some common vision, and a project plan. And how do we do that? And so there was always the argument here in Switzerland that, it sounds great what's happening over there in the States and what Mr. Graben tells here in his book. But in Switzerland, it's so different. It's not going to work here because of, the patients are obviously completely different, as you cannot compare a Swiss patient to a US patient. And especially our people are different. So what can you do with you have such a statement? What we did then is to try to measure, is there really any way to quantify how willing people are to change? Or the other way around, how is your resistance to change as a person? And so I'm not a psychologist, but I went and found one very important work from a professor in Israel, Mr. Orik. And he said, basically, I have developed a system of questions. It's not just asking you, Mark, are you resistant to change? Yes, no. But it's more sophisticated than that. And it claims to be the only system how you can predict reactions of people. So basically, if I tell you, Mark, unfortunately, I'm going to move your office next week to another room. You hear that information. You have very limited knowledge about if this is a good change. Maybe you're getting the corner office or in the top floor, whatever. Or maybe you're going to the cellar to the other logistics guys. You don't know that. But people tend to react to such an information in pretty different ways. And it's a pretty stable trait they have. Psychologists could explain that much better. And with a certain number of verified questions, you can find you on a scale from 1 to 6, what type of person are you? And this case in itself, 1 means that you love change, and 6 means you hate everything that happens without you in control, and you hate everything that changes. Your cup is not in the right place, you hate it.
That they might want to eat the exact same thing for breakfast every morning.
And they, it's not always change is good. You have routine work. So you need maybe in this planet both types of persons that are, you have to this morning, you have as every morning half an hour to check your email, and people will be more willing to do that. Other people will tend to hate that job. But anyway, so you can do this, and it was done across many, many different countries. And so, for example, here in the Central Europe part, the number is very abstract, but you have to compare it to make it meaningful. So the typical Swiss, the typical German would have something around 3.1. So in a scale from 1 to 6, so exactly more or less in the middle. So they don't love change, but don't hate it. The States, by the way, is a little bit more loving to change, 3.05. So This is like the benchmark.
It's not a huge.
It's not a huge.
It's not a huge difference.
So if you want bigger difference, go to Japan. There you have 3.22, meaning they are the most resistant to change. But they invented lean. So there you see. Anyway,
that's interesting.
You have this benchmark, and now you can, for the first time, compare those numbers with what's happening within a hospital. And my problem, or my first challenge when I did this study, was to see, well, if I ask the managers, they will for sure have a bias. Well, they're just telling you about them and about the great organization, and maybe they're the type of persons who became CEO, and so they might tend to be more change lovers. So what my aim was to try to really to get everyone in a hospital, from the CEO through all the physicians and nurses down to the assistant to the guy in the cleaning room. So to have really a representative view of the different jobs and roles in such an organization. And to make a long story short, at the end of the day, as I said before, if the typical Swiss citizen has a 3.1, the typical hospital employee was more change-loving, so with a 2.6. So that was a really low number, resistance to change. So the average person working in the hospitals, the 4 hospitals I observed, they would be more willing to accept change than the typical average citizen out there.
Interesting. Wow.
And so this is, that was for us a key result to start saying, guys, if you say change is not working in your hospital, it's not because of your people. It's maybe because of the, maybe even of the administration or the managers, or how you approach the whole thing. This is just not justifying not doing any lean projects in your hospital.
Yeah. Very, very interesting. Yeah. And I think when you talk about executives or other leaders, they might say they're change loving, but they're wanting others to change. Like if they were given the opportunity or pressure to change personally in some way, are they really as change loving when it comes to themselves? It's a good, interesting question. But I think you raised a lot of really good points about not blaming individuals for being quote unquote resistant to change.
Indeed, and you need to create like the burning platform. You need to create a vision, either positive, saying, imagine an organization where everything is on time. You're not wasting time with administrative stuff, or you have patients flow through organization, love you and give you compliments. Or you can start using the negative energy there is, like saying, that every day your operating schedules gets delayed. You know that you spend only 20 time with patients and you hate that. So however you do it, you need to create a certain sense of urgency to start a change. And the people, if they see that, and if you have a good plan, I'm sure they will follow you. And well, they have followed for many good cases I have seen here.
Yeah. So one other research topic I want to touch on, at least briefly. Earlier, you mentioned digital health, and you've also done research around digitization or digitalization, stumbling over the right way to say that, but lean and in digital advances and technologies. What's some of your research showing around? Or is it complementary to use digital technologies in lean?
Yes, obviously this is a hot topic, and everyone is talking about digital health. So I started to think, am I maybe betting on the wrong horse here with my lean? Should I also change, or should I? Maybe this is going to be the next big thing, research thing. And I think we can all agree on that. The order is pretty clear. You don't have to think about anything digital if your processes are not under control. If you don't start thinking, about the flow of your patients, of your information, what's really value adding, getting rid of the waste. Don't start with any automatization projects. Otherwise, you will just automate waste. So that said, the question is, do we need more digital tools and devices in our lean projects? So if you come to a typical hospital experimenting with lean in Switzerland, you will see a lot of paper. You will see that, okay, we are doing a Gemba walk and we are describing and drawing our value map. We will make this on paper. Mm-hmm. It will be a big piece of brown paper on the wall and we will draw there. Or if you go to a huddle in the morning of the nurses in a lean ward, they will stand in front of a whiteboard and move magnets around. You know. So the big question out there for me, the research question is, do we need more digital tools for that? And when I say research question, I don't have the clear answer. I'm just in the beginning, but what I noticed is that I had a workshop with around 80 practitioners from different hospitals. And I asked them exactly, what do you need? You know, you have done many lean projects in the past. Do you think now is the right step to move ahead? For example, there is one hospital in Interlaken, a Swiss city in the Alps. They have digital huddle boards. So it's a smart screen. So there is stand-up meeting is in front of that screen where can really not only move magnets, but move the data in their system around and use a keyboard and then it's written in the electronic health records and things like that. So is this just a toy or not? I don't have the clear answer, but what I noticed very fast is that with this 60, 80 people in the workshop, we developed around 30, 40 different ideas. So they were very, very eager to digitalize many of their tools. So that's not still a sign that we need them, but at least I notice from market perspective, there's a strong need and urgency of these practitioners to start experimenting more with that. And for me, from academia point of view, would be very interesting to see what's the added value. So if I have a smart screen compared to a whiteboard, yes, maybe I can do the documentation is easier. I can track things, and I believe, that's my thesis, that you will have some added value. But the question is it worth compared to all the costs, all the hassle you have there to install and to pay for that? So the cost-benefit ratio, I have no clear answer for that. So that's another hot topic.
Yeah, and I think one of the other ways of trying to frame that, whether it's digital huddle boards or digital technologies for sharing improvement ideas or completed improvements, I think kind of comes down to the question of what problem are you trying to solve. If you're a single site organization where people can spread ideas by literally walking to another department and talking in the cafeteria and looking at a physical bulletin board, the case of the argument for digital technologies might not be as strong as maybe cases where, like a thing in the United States, you have a hospital system with dozens of hospitals in different states. There might be a compelling problem statement where different technologies become a solution to that problem.
Yeah, I see that exactly like that.
And I think sometimes people, maybe, I don't know how much it's human nature, this would be a different thing to study. How much do people love jumping to technology solutions because they think technology is cool?
There's a current survey here from our association of physicians, and they ask, it's a representative study with family doctors in Switzerland. And they say only 13% say, nah, digital tools, we don't need that at all. So it's not only about lean, but just in our healthcare does not need digital tools. It's only 13% of family doctors. But if you start asking the patients themselves, the funny thing is it's only 44% believe that digital tools are important to improve the quality. I'm not talking about cost, the quality of healthcare system. So depending on whom you ask in Switzerland, you will get very different questions if we need more digitalization in our healthcare system or not.
Yeah.
And yes, obviously having a new digital tool, yeah, that's always a nice thing. Well, we are engineers, so you understand that.
Yeah. I mean, there are times, like even just personally, there are times when I think technology is cool and I want to do some sort of experiment with it. But then you see how that plays out. Like, in the past, I mean, it was maybe even going back 10 years ago, I experimented with doing some video podcasts where, let's say, we were chatting here, like the technology certainly exists through Zoom to not just record audio like we're doing, but we could have, made ourselves look nice and get on video and publish that on YouTube. And I did that. And, I got feedback from people saying like, well, I think most of the value really comes from what's being said. And, so in putting together a video podcast was, at least at the time, it was more effort. So anyway, I stopped that experiment. I just kind of went back saying, let's just do audio. And then, the other experiment is, do you publish a transcript? Because there are some people who either, maybe they can't listen or they just prefer to read. And so, there's questions around, okay, what technologies make information most accessible, whether that's the types of things we're talking about in a podcast or information about improvement or information about, medical records.
And it will be always a discussion. And I also have within my team, I have the discussion. For example, we have still a Kaizen board, and that's a whiteboard. So we have talked so many times about why we should be a role model and have some digital solution for that. But on the other hand, I have seen so many situations where people say me, yeah, we have a suggestion board. It's an Excel file and you can access it in this drive and in this 20 buried down between 20 different folders. No one is going to use it. So as always, purpose first, then technology.
Yeah. And then sometimes people get quite creative. Like there was a hospital in the United States I visited where, like, I don't think this was at all endorsed by the health system or the IT department, but within one unit, the nurse manager and all of the nurses had created a private Facebook group that they would use for communicating about, somebody has called in sick and I need someone to come in today. And, I think they were all very mindful. Of course, you don't make fun of patients. You don't post pictures of patients. You don't post medical information. But the thing I respected was that they were creative and they found a technology that solved a communication problem they had in a way that the hospital system had not solved that problem for them. And the hospital might have been upset, like, oh, you can't use a Facebook group.
That's true. So what you should the good part about the story is people came up with ideas. So you have already the people with the right mindset that we should try to find a solution and not just complain that our IT department is too slow. We are doing something.
Mm-hmm. Yeah. So before we wrap up, you've also been involved in the writing of a couple of books. I saw those books in your office, and the Lean Healthcare Transformation Body of Knowledge. Can you talk a little bit about that?
For sure. And unfortunately, I always focus on the market, and the market in Switzerland is very, very language driven, saying that if you'd say to a nurse, my book is in English, they will say, okay, then I'm not going to read it. So most of the things are in German. But if anyone is able to read that, if you go to my webpage, leanhealth.ch, what we try to do there, and in the book you mentioned as well, Lean Health Transformation Body of Knowledge, we try there to make like a Wikipedia of the Lean tools. Maybe with Google Translator, people are going to see that. So basically, this is like in 2 or 3 pages, I want you to explain me what is all the fuss about Kanban. Why should I bother? What prerequisites do I need there? So I try to gather the knowledge in one place, either a book for old-fashioned people like me or in the web page. So that was one of our research outcomes.
Yeah. Well, and it's great to have, when we talk about making information accessible, language certainly does matter. So, that looked like that was, a really useful guidebook for people who are trying to learn more. And I'll link to that book and in the show notes, and I'll also link to journal articles and other work that Alfred has done. But then you've got another book called The Better Hospital. I was curious if you could talk about that project.
For sure. So this was a project, as most of our projects, together with practitioners. So we got a grant from this federal government, and I took that together with the help of a consulting company in a hospital. And what we did there is we tried to tell one compelling story with easy words. So we went with a journalist, and he tried to convince us that not the most sophisticated sentence wins. So the other way around, you have to speak very clear, very easy to persons. And we have a lot of illustrations and comic book style. And we try to explain why should we bother with all this lean health stuff. And it was published in German, but this is one of the books. It's also available, at least through Amazon, in the Kindle version for sure, in English. So if anyone wants to have like this really journey for a person that has never heard about lean and the book tries to answer the big question, why should we change the way we manage our hospitals and other healthcare providers?
Well, and that's, an important point, the why before the what. Now, was it intentional? I'm guessing it was intentional to use the word better in the title, because that's, even though it's sort of vague, that sort of speaks to the why. We want to be better.
You want to hear the truth is we would like to use the term the lean hospital, but it was already taken by you, so we had to take another title. We did,
but I think it's a better. In a way, it's the word better, but it's a better. It's a better title. You think back to the days when Jim Womack and John Krafcik and others coined the term lean production. What if they had just called it better production?
Well, what I like about better is like the philosophy. You will never be the good, perfect hospital. So why don't try to be better? Every day a little bit better. So that, I think at the end it fits pretty well, the hospital and the title of the book.
Yeah. That's a great way of putting it. So every day a little bit better. Every podcast a little better. But you've been a great guest today, Alfred, and I know you're still with your own podcast in the early days. I bet there's a lot of incremental improvement that's happening from episode to episode. This is your opportunity to practice Kaizen.
Indeed. I was inspired by many podcasts out there, also by yours. So, I just thought, why, instead of talking and overthinking this, why don't we go out there, start? And what I heard is that after you need at least 20 interviews to be good host. You have now 350 and more, so you must be excellent by now. And I'm trying to improve myself as well.
Yeah. Well, it's good to have something that we're producing, and it's a process, and we can keep working at it. So Alfred, again, I want to thank you publicly for hosting me back in November of last year and arranging a hospital visit and some time to talk and compare notes and get to know each other. So I appreciate that very much, and I'm glad we could talk again today. And I haven't been able to share any perspectives from Switzerland. You're my first Swiss guest on the podcast, so thank you.
It was a pleasure.
Thanks for listening. This has been the Lean Blog Podcast. For Lean news and commentary updated daily, visit www.leanblog.org. If you have any questions or comments about this podcast, email Mark at leanpodcast@gmail.com.